Thanks, Ashley. Thanks to all our supporters again. It's great to be on tonight. We're gonna have a great time. We've got several great articles. We've got a great surgeon we're going to talk with tonight. I'll get to him in just a moment. Usually I have whoever comes with him introduce him, but I've got something I think I can read okay to tell you all about Dr. Safran. But first I'll introduce the rest of the panel here. I'm obviously Rob Mansky from Wichita State University. We have Barb Hoogenboom. Barb, you want to say hi real quick?
Sure. I'm Barb Hoogenboom. I'm the editor-in-chief of IJSPT and hail from Grand Rapids, Michigan and Grand Valley State University. Thanks for joining us for these awesome journal clubs. We appreciate you and your readership of IJSPT.
Thanks, Barb. Phil?
Hey, everybody. Phil Page, Baton Rouge, Louisiana, professor and research director for the DPT program at FranU. Thanks to all our sponsors and for the IJSPT, and especially Ashley for pulling us together. And thank you, Dr. Safran, for joining us. Mike,
you want to say hi? Tell everyone who you are.
Hey, everybody. Mike Voight from Nashville, Belmont University, and also editor with IJSPT. And I typically am in the background typing answers to questions or keeping these guys on straight and narrow. And Rob, I noticed you're not wearing earphones tonight. So
no,
you're going with a new look with this. But I wanted to be on tonight because Dr. Safran's a really good friend. Not only a colleague, but a good friend. So we're here to support him tonight. And we've got good articles to discuss. So I'll let you introduce him, Rob.
All right. Great. Thanks, Mike.
So if you hear, there's the cow. There's the cow.
Did you guys hear it?
I got muted.
There, I heard it there. I heard him then. Oh, that's funny. Way to start off. Well, so everybody with us tonight, we have our special guest, Dr. Marc Safran. He's a professor of orthopedic surgery and sports medicine at Stanford University. He's chief of the Division of Sports Medicine and fellowship director of sports medicine. He specializes in sports medicine, arthroscopic and ligament reconstructive surgery of the shoulder, elbow, hip, and knee. Obviously considered an expert of sports medicine problems of the hip, elbow, knee, and shoulder. And he's with us tonight to talk about hip issues. And he sent us a couple of articles that we're going to discuss. So Dr. Safran, thank you. Can you is there anything else you want to tell us about yourself before we start?
I'm honored to be here. I appreciate the invitation. And I think some of you know, I mean, my area of passion for the last 20 years has been about doing hip and hip arthroscopy and non-arthritic hip problems in athletes, and particularly hip microinstability has been an area that I've particularly focused on and trying to get people to believe in the concept that it exists. And certainly, like most things, the physical therapy world identified it before the orthopedic world did. And so I'm just trying to get the orthopedic surgeons to actually believe that it exists as well. So that's why we partner up. So.
Well, it's great to have you on. And coincidentally, do you guys all get emails from ViewMedi? You know what ViewMedi is?
I just saw a really good one on microinstability this week.
That's what I got. I got what it sent to me today. Literally this morning, I got an email of Dr. Safran, your talk from South Africa on hip microinstability came to me this morning. Perfect.
Well, you're in Wichita. It's a little slower getting stuff to Wichita, the stagecoach.
That's right. That's right.
Yeah. It only took 9 months.
Yeah.
I gave that talk in October.
That was, October 23. Amazing. All right. Well, so our first article, let's go with, do you know how to pronounce this name, Dr. Safran? Is it Kauai? So from Kauai, it's the short-term outcomes of physiotherapy for patients with acetabular labral tears, an analysis according to severity of injury in MRIs. So thank you. These all of these articles are great. I think we're going to have a fantastic discussion with all of us, and of course, obviously, you being the key partner in this. So thanks for choosing these great articles to start with. This study in particular, I think, bears a lot of great clinical implications. It's a retrospective review. And I mentioned here that, a lot of times you think, well, retrospective review is really a pretty easy study to do because you're just looking back at data you had prior to. However, if you really think about this, you have to have, you know, the right people helping you gather the data, to do the test, to be able to pull off a study like this. And I'm sure you've done multiple studies like this or several studies like this. Can you talk about the difficulty, Dr. Safran, of doing research like this with actual, you know, patient populations that you're seeing?
Well, a couple of things. I mean, if you're doing it over a long period of time, you know, you may change how you do an examination, or you might add a new test in that you've learned about. And so, you know, when you're doing it prospectively, you're looking at things the exact same way and make sure you're asking all the exact same questions. And that way you have more complete data set. So a lot of times you'll have missing data, you know, on patients, and that makes things difficult. Also, making sure you're getting adequate follow-up on the patients. Sometimes they're doing well, then they don't want to come back, and then you don't find out that they're not doing well and they've gone somewhere else to get surgery or something. So, I mean, there's always those holes of both getting the data as well as how you're even doing the data, so retrospective is nice as a first look. The way I look at it, you know, we had talked about the levels of evidence, and it starts with, you know, kind of expert opinion, and then it kind of goes to, well, you do a case series and see how they do, and, you know, retrospectively go back, you know, did it work or not, before you get to, you know, doing a prospective series or randomized controlled trial. The problem is, you know, people say, well, they all want the randomized controlled trial, but everything has to go through stages. You have to determine, first of all, does this work before you're actually going to try a randomized controlled trial? So you're going to have to do a few cases, see how it does, then maybe do your retrospective study to see how it does before you're going to do something prospectively. So, most of the research starts at it, but we also find that the higher level of evidence, you're oftentimes with a prospective study, and certainly a randomized control study, you take out the bias. You know, with a retrospective study, you may have already had some bias in who you select to send a therapy versus the ones that you're not. So, if you take all comers and define that ahead of time, you have a much better study, but you got to start somewhere. And so looking back retrospectively, I think understanding the limitations, understanding their holes, as we kind of mentioned, you take it for what it's worth, but I think it's a way to start.
Yeah, I agree. Phil, you got anything to add?
No, it was great, Doc, because we try to explain to everybody that levels of evidence are important for clinical decision making, and you outlaid it perfectly to know that these are just observational studies, like you said, and clinicians have to be able to say, where's the potential bias here that would influence? I can't just use the results of this study at all on making inferences on my patients, but I can use the information to start with. And plus what you said was great. It leads to the next step. And that's the important thing, is can we get this information to that next level?
Great points. Great points, Phil. Dr. Safran, this study looked at some of the variables they looked at were the prone external rotation test and the traction test. For people that haven't just, you know, got on, haven't actually read the article yet, can you describe those tests for us? And are those, the other thing I want to know is, are those kind of your go-to tests also, or are there other tests that you use that maybe seem more valuable or more important to you?
Yeah, so we actually did a study we published in 2017 looking at 3 specific tests for hip instability, and actually used as a gold standard intraoperative diagnosis, confirming that they actually had microinstability. So when we did that, there were 3 tests. Only one of them was used here. And the one that was used here is that prone external rotation test, which we found actually has is probably the least sensitive of all the tests. Actually, it was only sensitive in about a third of the patients. However, of those patients, if that test was positive, 98% of them actually had an intraoperative diagnosis of microinstability. So low sensitivity, high specificity test. So you're going to miss a lot of people that may have microinstability with this test. But if this test is positive, you could feel pretty confident, yeah, they probably do have some microinstability. The traction test, I actually had to look at what they were doing. Oh, let me go back. So how you do that test, you have the patient laying prone, you externally rotate, so their hip is a neutral flexion extension, you externally rotate that extremity, and you push down on the greater trochanter. So you push an anteriorly directed force on the greater trochanter. And if that causes pain anteriorly, then that's supposed to be suggestive of hip microinstability. What we find is that mechanically, if you extend the hip, just based on the lever arm, the femoral head wants to come anteriorly. If you externally rotate the hip, femoral head wants to come anteriorly. And so most microinstability is anterior instability. It can also be lateral. So most of the tests involve either external rotation or extension or combination of the two. So the prone external rotation test is neutral flexion extension with external rotation. The two other tests that we like, one is called the hyperextension external rotation test. That's for the patients at the end of the table. Actually, if you want, I will, I can show you. Let me do this. You mind if I share?
I think so. Is that Ashley? Is he able to share the screen?
Yeah, is it, do I need to make, here, hold on, let me make you a
Might have to
co-host.
open it for everybody.
Try that.
Okay, so let's try it again. Perfect. Okay, I got a lot of stuff on my table here. Oops. Here we go. Let me. Can you see a thing that says prone external rotation test?
Yeah.
So if you see they're prone, I externally rotate and I push down on the greater trochanter. That's the prone external rotation test. The one I found is the most accurate test is this test. The patient's laying on their side. You abduct around 30 to 45 degrees. You extend the hip. You externally rotate it and put an anteriorly directed force. And if that causes pain anteriorly, we find that that has the highest sensitivity and specificity, about 81% sensitivity and about 89% specificity. And then the hyperextension or external rotation test, the patient's at the end of the table. They hold on to one leg to stabilize the pelvis, and then you just externally rotate it. And again, that's hyperextension with external rotation in neutral flexion extension. The abduction external rotation test is in slight abduction with extension and external rotation. So some combination there, and those are the three tests that I do regularly. The extension, the axial distraction test, the only one that I know of, the axial distraction test, was described by Steve Aoki that he published in just before or just in the beginning of the pandemic. So I have a picture. This is of me with a patient. They're slightly abducted. They're slightly flexed, about 20, 30 degrees of both. My knee goes under their ischial tuberosity as I'm applying an axial distraction force to or pulling on their upper leg, basically. And so sometimes they feel unstable. Sometimes they feel pain. Sometimes you can actually feel the head shuck out of there. When you look at the paper, though, the paper actually has I can go. Let me go back to it. The paper actually shows. Sorry, these are my notes on the paper. Them basically just pulling. Here he's doing the external rotation, the prone external rotation test. Here he's pulling on one leg. Yeah, he's just pulling on one leg, and the other leg he's either pushing or whatever to make sure they don't fall, just pull off the table, is my guess. And so I haven't seen that test described like that before. They didn't report any numbers to it, but this is what the examiner, the author of the paper, was using as their traction test. And those were the two tests that they were using to detect microinstability, which, again, only one of those is a test that's been validated, if you will. And as I said, probably the least sensitive of all those tests.
Yeah, those are good. Those look really good. And that I think you're right. That I like to be honest, I like the position that you had in your traction test versus when they're fully extended, because your position is going to have them, I think, more in really kind of a loose pack position where you might feel that more often, I would think. Ashley, Mike, do you guys use the same tests that Dr. Safran does? Do you use any different ones?
Those are the ones we learned. So from him, he's my mentor in this one. So yeah, that's what we do. And I think Ashley I don't think we have anything different than that, but that's the ones that the go-to ones that I've learned through Marc.
Yeah,
Just
we do.
go ahead.
We do as he tells us.
Yeah.
I love it.
I have a couple questions real quick, if you don't mind. So
No, jump in, Phil.
what I liked about the test you're describing, Doc, the two questions or an observation. One, it sounds like this is just like, your shoulder apprehension.
Mm-hmm. Uh-oh, we lost him.
Phil
He's
froze.
frozen.
He's deep in thought.
Yeah. It's weird how he likes to think with his mouth open like that. Most people close it, they breathe through their nose a little bit. Phil does it with his mouth wide open like that. Yeah. Okay.
While he's got his mouth open and he's thinking, I was going to say that I just really appreciate, Dr. Safran, the way that you and your team have looked at sensitivity and specificity and looked at that to say, we're going to test with something that has some veracity or has been studied, and that's really important. So I think I just want to give you kudos for that, because then Mike and Ashley and others do what you tell them, because we know that you've looked into those things and you've done the work on the clinometrics and their predictive value.
All right,
Sorry,
Phil,
Phil, you froze.
Phil, you're back live.
Back,
You
you
froze.
froze.
For a bit, so we
Must
didn't hear
be
your
the tropical
question or your
storm
statement.
Alberto.
I thought you're fooling around with cryo chambers or something.
Yeah.
The question, I don't know if it got answered here, but that was the question. But Barb was actually asking was, when you say that you had.
Oh
He did it
no.
again. He's
Jeez,
doing it
Phil.
again. Yeah.
Cut him off.
Phil,
right.
text us your comments
Your
and
question. I'll
say
text
them.
him a question.
Oh, that's fine. We should have him just send it. Yeah, send it. Phil,
Yeah,
send
send
your
it in the
question to chat,
Q&A.
and then we can ask for you. All right, so let's move on. Dr. Safran, what other processes do you have, like in your standard evaluation scheme? What other kind of keys are there that you look for in someone with micro instability of the hip?
So we published a paper a few years ago showing that if you measure the patient's range of motion, laying supine, their hip flexion, plus their rotational arc, so plus external and internal rotation at 90 degrees of flexion, you add them together, and if it's more than 200 degrees and it's a woman, she has greater than 90% likelihood of having microinstability diagnosed. And if it's a guy, it's about 75%. So your hypermobile patient, I think those are clues. I look at it when they're just laying down, when I'm about, I ask them to lay down on the table after I examine, their iliopsoas strength, their seated hip flexion strength, and after I do my Trendelenburg test and all, I have them lay flat, and I just, first of all, look at how they're laying. If they have, one leg might have increased external rotation than the other, the foot is laying in more external rotation. So that's a sign of iliofemoral ligament insufficiency or laxity of the iliofemoral ligament, or it's a femoral version problem. But, increased external rotation, if the iliofemoral ligament is lax, that's the anterior ligament that's preventing anterior translation, the anterior instability. So, I just look at that right off the bat. I do those instability tests. I also palpate for iliopsoas tenderness because, the iliopsoas, I think, is the main stabilizer for anterior stability of the hip. And so not only do I check iliopsoas strength, I check for iliopsoas tenderness on exam when they're supine. So, those are some, I think, the key features. There's a couple of other tests that I'm trying. We actually are, we finished collecting the data on 1,000 patients at multi-center, on 1,000 patients at consecutive patients at 5 centers with intraoperative confirmation of what their diagnosis was. And we're trying to find what are the best tests to evaluate for instability. So we did include that axial distraction test that I showed you that Steve Aoki had described and taught me. And we also included the so-called PART test, the P-A-R-T test, which is the prone apprehension relocation test, where you have the patient laying on their belly, you abduct them about 10, 20 degrees, and then you hyperextend their hip, and then, or take their knee basically off the table, so it's hyperextending the hip a bit, and then you push down on the proximal femur just below the gluteal crease and see if that reproduces pain or apprehension anteriorly. That test is gotten popular with some groups, though the only test that they actually compared it to in the original paper was the hyperextension external rotation test, and they found that it didn't correlate. And in my mind, that's a really good test because we correlated that surgically. So they haven't correlated theirs with surgery, but we're testing that as well to see. And so we're waiting to go through the Stanford bureaucracy about sharing of data.
Yeah.
But five institutions. We're 9 months into that right now. So
Oh my
eventually it may come out before the Olympic Games in Los Angeles are done in 2028.
Fingers crossed. Yeah, everyone's hopeful.
Rob, I'd throw this out there. I know I've shared this with Mark before, but I'd be remiss if I didn't throw this one in when you asked about special tests that we do. And I know at Isicos, I shared this with Dr. Safran, but one of my other mentors, specifically in this area, and I think was a pioneer in the physical therapy world for this, was Dr. Shirley Sarman. And this sort of reminds me of an anterior sort of femoral glide in her test, with the femoral head staying in a precise rotated position or rotation. And what the other easy thing that I do a lot of times is, you just come in on that inguinal crease and get right mid inguinal crease with your thumb over the femoral head there, and have them go into you can do passive, we do it passive and active, but bring them up into hip flexion. And if you have a precise centralization of that femoral head, your thumb should stay in the same place. It's not going to move. But when they have that subtle micro instability that we look at, your thumb will rise superior with that. And I look at it both passive and active, because a lot of times if we put our thumbs on that crease, bring them up into flexion, it looks really well passively. But when you have them take hold and hold that the femur up, you'll see that thumb just ride straight up. And one of the things I sort of do as a follow-up to that, and then it's just a variation of it, is give digital pressure on there. And if I can reduce it and get it to stay there by myself, I think that's a strong candidate for our rehab programs, particularly working on those deep rotators to help centralize. But I know Dr. Sarman's on the call tonight on the Journal Club, so welcome for joining. Yeah. But I wanted to give a shout out there because I know she is one of the pioneers on that anterior femoral glide. Has been one of her mainstay things she's done with looking at that and coming up with the test. So that's another one that I do a lot of times in clinic with this as well.
I was going to call you out for brown nosing, but okay.
Yeah.
No, I do have slides and videos of Dr. Sarman doing the test.
Dr. Safran, do you use the Baton scale, don't you? Just of generalized ligament laxity. Have you found that it correlates highly, like a higher score on the Baton scale? Does it correlate higher with people that have instability? We did a we did a little study with swimmers and their shoulders years ago that we didn't publish, but it doesn't really correlate high with laxity of the shoulder. And so I wondered if it's kind of the same way at the hip. It may not necessarily, you'd think it would, but it doesn't in the shoulder. Does it in the hip? Do you know?
Yeah, no, and I know Christian Gerber looked at it, and he did publish, showed that Baton's scores does not correlate with shoulder instability.
Yeah.
And so we did not find that it correlated. It was interesting when you talk to different authors about what they use. But for some say, Baton's a 4, some say 5, some say 6, and that number's all over the place. So we included that in our study of the 1,000 patients. So we will see if there is a threshold.
Oh, awesome.
But to this point, we have not found. I just think that if you see patients that are loose jointed and have, several positive Baton signs, then you should be alert to look for the instability, because it's one of those things that I say that, if you don't look for it, you're not going to find it. But if you start to look for it, you'll see it all over the place. So
exactly,
I think those with generalized laxity are probably more susceptible, but they don't all have instability.
Gotcha. So Ashley and Mike, I want to ask you this one because Dr. Safran sent me an email earlier. We were discussing this a little bit. In that article, there was a concept of exercise. It says doing exercise to increase centripetal of the femoral head in the acetabulum, and I think I'm saying that right. Does that just mean doing exercise to stabilize and center?
I use the term centration. I don't know centripetal. Joint centration.
Said centripetal.
Yeah, we just use joint centration, but yeah, trying to decrease that anterior glide essentially.
By doing various.
Yeah, I mean, usually it's for us, we focus a lot on the posterior hip, the deep rotators. And it's really amazing. Sometimes you'll see people come in and they're presenting with, we see this post-op too, just unrelated to micro instability. They're presenting with more of like an impingement, hurts inflection, internal rotation, get their deep rotators firing, flip them back over, move their hip around. All of a sudden they don't have any of that pain. So it's a nice, quick, down and dirty way to kind of show the patient like, hey, you have control over this situation versus something's going on real bad in your hip joint.
Yeah, so it's really a lot of that. This analogy is very similar to the shoulder. Then, really, I mean, the instability.
Yeah.
I'm like you, Rob. I
Rob-
couldn't say centripetal tone. I still can't say it. It took you
Yeah.
4 tries. Centralization, but I just think it is joint centralization.
I thought it might be a language convention, to be real honest with you, because like I was thinking, yeah, centralization, I think it might have been a language thing personally, but
Could have
Well,
been.
you're an editor. We live in Tennessee.
I would have asked them what that meant, but yeah. Use plain English.
Phil, this may be a good question for you. Eight of the participants still required surgery in this study. So overall, most saw improvement, all but 2. Is that consistent with what? I guess this isn't for you, Phil. This isn't a stat question. I was thinking this was a stat question I was going to throw at you. This is more for Dr. Safran. Is that consistent with the patient you see, the percentage you see in clinical practice, Dr. Safran, that end up needing surgery?
Yeah, so it's interesting. We looked at 64 patients a few years ago that had microinstability, that presented to me with microinstability, or what I thought on the exam was microinstability. And I sent them for all physical therapy for strengthening the periarticular muscles and the core. And with an average of about, with a minimum 2-year follow-up, average of 4-year follow-up, so 35% were essentially cured. About 20% were significantly better, didn't want surgery. About 20% or 15% were no better and didn't want surgery. And 30% came to surgery. So a third of them ultimately came to surgery in an average 4-year follow-up. So yeah, I mean, I think the issue is, why did they become unstable? And really where are the symptoms coming from? I think a lot of times it's, weak muscles, muscular overload, trying to dynamically stabilize the hip. And if you can get them strong again, then they can do fine. Again, I find a lot, shout out to Dr. Sarman, the hamstring dominance issue and getting them to fire their glutes, I think makes a difference. And I think if you do the proper rehab, a lot of those people will get better. I think also nowadays, I see a lot of people that come to me even with hip impingement, anatomy, MRI with labral tear, because everybody has labral tear, but they actually have iliopsoas tendonitis. And if you send them to therapy, they get better, and they get better. What I think a lot of times happens is a lot of people get operated on because they have an MRI that shows a labral tear, and they have the anatomy of FAI, and then they get the therapy after surgery that they could have gotten before the surgery to get them better.
Yeah,
So,
exactly.
Yeah.
Hey, Ashley or Mike, Taryn, we have a couple questions. People sent in. Taryn sent a question. Can you go over some of the exercises for the deep external rotators to help center the femoral head?
Ash, you want to walk them through the program real quick? The Takla O'Donnell modified program, I guess.
You want me to walk through the whole program?
No, but just give a quick version of it. I mean, I know we have 12 steps, but
yeah. So we'll usually start, and you gotta bear with me because I've been sick for 3 days, so we're going in and out here with the voice. We start prone on their stomach, doing just kind of a tactile cueing activation of the deep rotators, with the knee bent and kind of in a slightly externally rotated position. Once they can kind of show us that they can fire in that position, then we'll move to some active and resistive exercises in that prone position, moving up into quadruped. Just some active and resisted external rotation stuff in quadruped. We do one that's not in Amir's program, I don't think, in the quadruped position with the hip extended and foot against the wall, down out, like not even at 0 degrees of hip extension. So slightly in a slightly flexed position, but knee fully extended with the foot against the wall on a towel. And we have them internally and externally rotate there, kind of like a mortar and pestle movement, and really focusing on using those deep rotators. And then we'll move that up we'll get into quadruped position, or I'm sorry, kneeling and tall kneeling and half kneeling positions, and working pelvis rotation over femur. Because again, it's important that we go, a lot of that initial stuff we do is open chain, but we have to remember that, the pelvis rotates over the femur as well. So we move into some of those weight bearing positions, and progress through some loading and control in those positions as well.
I think Dr. Safran would agree, because we've lectured with him and shared a lot of data, and Ashley could corroborate. But I think a lot of times people think that those working on those deep rotators are, I will say this, it's kind of a boring exercise or boring series we go through. Everybody likes to work to the big prime movers, get out to glute med and working that. But the reality of it is, in our experience, those are those fine tuner muscles that really make the difference in a lot of the hip pathologies we see and working on it. And I sort of think of it this way. When you look at them anatomically in isolation, they are small rotators. But there's studies out there that look at it. If you combine them all and look at the total cross-sectional diameter of the muscles as a whole, now we're starting to approach something in the neighborhood of the glute min to glute med. So they can be quite powerful in this. And we believe those are probably the key to helping that. What do you say, Rob? Centripetal or something? Centralization.
Centripetal.
Centralization of that femoral head.
Hey, I've got to tell you guys ahead of time, Dr. Safran was really downplaying his role in this earlier today. We have 200 people, Dr. Safran, listening tonight. And I think really, I mean, we've had a lot of good speakers, but you've took control of the screen. You're answering your own questions on the question and answer. This guy's a rock star. He's like saying, "Oh, I don't know if anyone's going to want to listen to me," but he's like all over the board here and everything, man. You're killing it, Dr. Safran.
And at the beginning, he says, "I hope I don't mess it up." I'm like, "Not possible.
I hope I don't mess
Not
it up.
possible."
I don't think we've never had a speaker go on and answer their own questions on the chat and question and answer. Dr. Safran's answering his own questions. We don't even have to bring him up because he's answering them on the chat.
And Dr. Bird didn't even do that with us.
No. Incredible.
I know the bar is very high. I'm trying very hard not to flub up.
You just topped Buddy Savoy on this one.
Yeah, you might have.
You did.
Yeah.
Wow.
Oh, God.
Okay. Wow.
Fantastic.
Sorry, Phil. But he
All
can't
right,
answer.
next
He's
question
frozen.
I have, guys, the next question, this study was obviously out of Japan. I think the average number of PT sessions was 3.3 a month. And so what I wanted to ask Dr. Safran, do you have a number expectation of like how often is someone seen if you send a patient for therapy? And Mike or Ashley, do you see people like, is it once a week or less than once a week that you see people typically? Is that standard here in America for you guys?
I mean, I'll tell you, I want them to get at least 6 weeks of rehab because I tell them it's going to take at least 6 weeks before we can see a difference. And I write for twice a week for usually 2 months because I figure they may not get back and see me in exactly 6 weeks. So so I write for 2 months. But the reality is, I tell them I want them to do the exercises every day. And in many respects, for a lot of these exercises, the therapist's like a coach, tell them what to do, how to do it, and then they need to go do it. So I want them to do the exercises 5-6 days a week. And some are, I find that some patients will do it twice a week, the 2 times they can go to PT because they say they don't have time to do the exercises, but somehow they manage to find time to go to PT. And then there's the other people that, don't have the time to go to physical therapy, but will do the exercises on their own. So, so ideally it's, can they get 10 times, I'm sorry, can they get, 30 days of rehab in the next 6 weeks, of exercises that we want. And if they can, then great. And so whether or not that's all in PT, a lot of it depends on the insurance and their time, that sort of stuff. So.
I hope I don't freeze up here, but real quick, one of the things is that when we look at studies in other countries, it's important that we take that into consideration. We're applying it to our patients. And in Japan, they tend to have more of a traditional, they're always going to be compliant. They're going to do their exercises. You can really rely on them to do that as part of that, as part of the Japanese lifestyle. So I used to do a lot of research in older adult exercise programs, and compliance was a huge part of it. And you could always tell that they were very compliant, but in America, you may not have the same compliance.
Yeah.
Isn't that the truth? So what the other thing this study talked about was a significant number of these people, I think it was 63%, had extra articular hip pathology also. That seems to be pretty consistent. Do you guys agree? It's rarely isolated, the instability.
Yeah, I mean, I look at instability, you know, it's kind of like when people say, well, what do you see pathology-wise in the hip? And we talk about labral tears, chondral injury, ligamentum teres tears, but the mechanism, the those are the results of microinstability, or that's the results of FAI, right? And so I think that you get compensatory patterns and you get issues where people develop, you know, when they have microinstability, they'll develop iliopsoas, you know, issues, and then TFL and glute med as well. So, you know, those are all pretty common periarticular or extraarticular issues that I don't think you can exclude, you know, that goes along with the intraarticular pathology, but I think it's all part of the same process. It's just where you are and in that process.
And
That's my
treating
thought.
it, like the treatment of it really comes down to understanding that whole like source versus cause. Sorry, I knew he'd show up at some point. And you have to treat it all, but you have to realize, you know, if the iliopsoas is really lit up, you have to understand that the underlying reason why it's lit up. And so a lot of the mistakes we see is that you focus on like soft tissue work on the iliopsoas and iliopsoas release, if you will, but not the fact that the reason it's so flared up is it's trying to compensate and stabilize for this microinstability. And it just, you're fighting a losing battle. So while sometimes it does need the hands-on to decrease the pain, the inflammation, a lot of times it actually needs more strengthening, which sometimes is counterintuitive because they're coming in complaining that it's painful and tight when really it's just irritated.
Yeah, it's not tight at all. Yeah, exactly. Janine asked the question, essentially what she's saying is conservative management in FAI historically has been considered about 12 weeks. So I think she's asking, I think maybe Dr. Safran, you said you want them to have at least 6 weeks. I think what she's getting to maybe is, should conservative management for microinstability with strength-based focus actually, should it last longer than that of FAI, or is 6 weeks enough?
No, I tell them it's just going to take at least 6 weeks before they notice a difference, right? They're not going to have full strength in that time. Certainly I find, at least in my practice, and maybe it's my patients or wimps, but it takes a long time to get all that iliopsoas strength all the way back, you know, where you get to where you can't break their seated hip flexion strength. So, I mean, I think it takes a while to get there. And so, yeah, most people, I want to see that they're making improvement by 6 weeks, 2 months. If they are, then we continue that course, but that's usually not the end of the game. I don't expect them to be cured in 6 weeks. I just want to make sure they are improving. And if they do, then we're on the right track. If they're not, then we may need to sit there and shift. And in that situation, maybe if they're being inhibited by pain and they can't do the exercise because of pain, and it's from the iliopsoas, we'll get them an ultrasound guided injection with some cortisone for the iliopsoas, or intra-articular if it's the joint that's really more inflamed than the iliopsoas, to allow them to be able to rehab harder. Yeah, I mean, it's not, I know D'Alessandro's work with 12 weeks and the injection for the FAI. You know, I think when it's all said and done, and if we looked at actually how long my patients were in therapy, I'm sure it was at least 3 months of rehab.
I just want to go on record and say that Dr. Safran just corroborated what we already know, that the athletes out there that he has in Palo Alto are soft.
We're gonna find out. We're gonna find out how soft now that we're joining the ACC. And,
Exactly.
I have to go play some games in the South.
Exactly.
Also, I
All
put a PDF of the deep rotator progression from Amir, and shout out to Amir is on tonight. I'm thinking he's in Australia and he's on here. So
Wow.
a big thanks to Amir for all of his work.
There's the cow.
There's a cow
again.
Cow. Oh my gosh. What are you doing to the cow, Mike? Good Lord.
His dog's attacking the cow.
Are you guys, I still had some more questions with this study, but we're like way past the 30-minute mark. Do you want to go ahead and move to the next paper? Is that okay with everybody? Yeah.
I want to hear about capsular plication.
Capsular plication. Okay. The next study
Hold
is
on one sec, though.
Oh yeah, go ahead.
Just Mako Moritani asked if patients with hip dysplasia, limited coverage of femoral head automatically fall in the microinstability category, because this leads to that editorial that was in there from that I wanted to talk about. So I took a lot of heat calling it microinstability, but I come to it from the sports world, right? Where in shoulders we talk about microinstability. Either they dislocate and that's instability, or they don't dislocate and that's microinstability causing symptoms maybe of instability, maybe not, dead arm, rotator cuff symptoms or whatever. And so the adult hip preservation or pediatric preservation surgeons used to say, all dysplastic patients have instability, and that doesn't necessarily mean they dislocate, but they have instability. So we get into this nomenclature thing about is microinstability, instability, and vice versa. In all reality, is that what we also find is that not everybody with dysplasia actually has instability either. So Martin Beck, a lot of these patients have a shallow hip socket that have a femoral head that's out of round. So they have cam anatomy and they have dysplasia, and particularly see this in your borderline dysplastic group. And so he actually was, thank goodness, because he's one of those classic hip surgeons, said, look, some of these people have instability and some have impingement, and so there's a difference there. So in my mind, if you have dysplasia, I do think you're at more risk of having microinstability, but just because you have dysplasia doesn't mean you have microinstability. So hopefully that answers your question.
Awesome.
I think there was one other question in the chat. I think it disappeared, but about success with microinstability with dancers. And I'd like Dr. Safran's answer on that, and from his perspective. I know what mine is, but
I think microinstability in dancers, I mean, your hyperflexibility sports, your dancers, your artistic swimmers, your gymnasts, I mean, it's a tough group to try to treat. And so, what I always say is that they have to either have some dysplasia or some laxity of their capsule to be dancers, because if they're not doing the splits by the time they're 12, they're going anywhere in dance. Right. And so you're selecting for people that are susceptible for instability. But if you take away some of their mobility, then you run into problems. And so, again, we try super hard to try to rehab these people. They oftentimes don't have really good strength and all. And in that case, I think doing the capsular plication it works well. In my experience with the dance has actually been very good. It's not what it's been for everybody else. I think that's a function of how the plication is done. And so the way that a lot of people do the capsular plication is the way they do their hip arthroscopies. They'll do a two-portal arthroscopy. They'll use an anterolateral portal and a mid-anterior portal. And then they basically cut the capsule between those two portals. And so in 2011, we showed if you do that, anatomically, you're cutting the entire iliofemoral ligament across. And so that's obviously your main anterior stabilizer. So you're going to make these people decompensate. And so since then, people have started to do capsular plications by actually not just closing the capsule, but kind of imbricating the capsule where they've cut the iliofemoral ligament. The problem is if you're now tightening the iliofemoral ligament, you're going to lose external rotation. And so Ben Dome showed that he lost on average 11 degrees of external rotation in his people that he did the plication. Again, you lose 11 degrees of external rotation in a dancer, that may be significant as far as their ability to perform. So I do a laterally based plication. It's between the iliofemoral ligament and the ischiofemoral ligament. So I'm not tightening either ligament individually. And I think that's why we don't lose the range of motion. And my analogy for it, again, because I come to it, was I was trained classically as a sports shoulder and sports knee guy, is like the rotator interval closure that we used to do in the shoulder for multidirectional instability. You don't just operate on the anterior inferior glenohumeral ligament. You operate in that area of the capsule where there is no ligaments, and you tighten it up, and it tightens everything a little bit, and not over tighten any one specific thing. And so the same thing in the rotator interval. I close that rotator interval of the hip, what I call the rotator interval of the hip, and that tightens things a little bit, but we don't seem to lose range of motion. So.
All right, fantastic. You guys want to move on now? You want to move on for the next? We got like 15.
That was a good segue into capsular plication.
Yep. All right. So the next paper is by Charles, Treatment of Hip Microinstability with Arthroscopic Capsular Plication, a retrospective case series. So anybody got any questions to start, or you want me to start? No? Silence? Crickets? It's me.
Everybody takes one step back, leaves it for you, Rob.
There you go.
It's you.
There you go. So, Doc, tell me what one of the kind of big questions I had here was looking at they talked about how many people failed conservative therapy. So can you Can you describe what you mean by if you said, well, someone failed conservative therapy, what does that mean to you? And my reason I'm asking this is, like if I don't know how good of a hip therapist Phil is, but if someone fails hip therapy from Phil and I think it's a total different situation than if they failed it from, Mike or Ashley. So
Agreed. We'll
how
agree with
much?
that.
No, I know.
Probably true.
I knew you
And I
would.
probably
Oh,
go
wait,
with
is there
you
a
guys. So
question?
yeah.
Okay. Yeah, it is kind of loaded. But so what, like, how much does physical therapy expertise in that given population play into your decision to stop rehab and try surgery versus continuing rehab?
Well, I mean, basically it comes down to when I examine them, but ideally I try to navigate my patients towards therapists in the area that I think are good with hip related problems. The problem is a third of my patients come from more than 3 hours away, so I don't really have a lot of control over it. So I have them, we give them a set of exercises. I try to write as clearly. I give them a patient, handout as far as how I want them to strengthen their iliopsoas, things like that. And then when they come back, that's why I have them come back and I examine them. I want to see what the strength is like. I want to see how irritable the hip is. Make sure that they've resolved the iliopsoas issues or things like that. Most patients, when they fail, have got now good strength, but they still can't get back at the activity level they want to get at. Some people have too much pain that they can't really rehab it. Those are the people, as I said, that we then get them an iliopsoas ultrasound-guided injection. I've had the only couple of exceptions I've had for that is I had a patient, it was very interesting. She wasn't progressing the way I was hoping or that she was hoping, but she was getting stronger. And so I was like, let's continue the course. And she ended up getting another MRI probably about 6-8 months after. And so I had an MRI before I first saw her, and then about 8 months after. And she now had developed some edema in her anterior acetabulum, which I think is her femoral head translating anteriorly, overloading. And then I said, you know what? We need to cut bait here, and I need to stabilize your hip because I could see this going downhill in a hurry. So, but generally, it's based on their strength and making sure that they gave a good effort at trying to do the rehab.
Would you, so when you see them, you said they get stronger. That's the to me, that's what I find frustrating with a lot of patients where they like objectively they get better, they're getting stronger, but they still have their symptoms. That's obviously frustrating, and I think something you have to look at and take into consideration. When you do, so they come back and see you and you do your special test with them again, most of the time, would you say if they responded well, most of the time when you do those tests for microinstability, they're negative at that point? Are they negative symptomatically, or like the distraction test isn't really a test of strength, it's really just kind of a test of their laxity. So are some of those tests still positive even though they're not symptomatic?
Yes. So sometimes patients, it would be great if, those tests all became negative pain-wise, but, I'm putting them in positions that they don't normally necessarily go in. And so the key is, do they have good strength? If they have good strength, and then you start to return to sporting activity progression and they can't get back to the level they need to get at, that tells me something. But if they can get back to the level that they need to be at to perform and they're not having any pain or discomfort, just because I can make them hurt in my clinic doesn't necessarily mean that they need to have something done. So the issue is that, so again, sometimes there's a straw that broke the camel's back. So now they're strong, but they're still symptomatic in spite of being strong. And those are the people that sometimes, those are the people that, for that third of patients, if you will, that then I say, well, surgery is probably the way to get you back to the activities you want to do.
Yeah. So you said a lot of your patients obviously are from out of town. Do you every time you see someone that's from out of town, if you don't know the therapist, don't know any therapist really where they're at, do you usually have your therapist in your clinic see them before they go back to wherever they live, or do you just send them, let them go to wherever they go, and they don't see anyone at your place before they leave?
I don't have the luxury of having a Mike or Ashley around.
You know, okay.
I have some patient, patient handouts, from in my general office clinic. I have some patient handouts that has photographs of with descriptions of what tests I want them to do. And then I tell them if their therapists have any questions that they can call our therapists at Stanford.
Mhm.
You know, we're very fortunate to have a separate place for our Stanford athletes. We're just our varsity athletes. We have a set of therapists that work with them. They're all really outstanding. And so they will, if the patients are going home for the summer and they're not staying around, they'll communicate with their therapists, and they'll also come up with a detailed program for the athletes to take with them. So, but that's a unique situation. But otherwise, I don't have the luxury of having a therapist in my clinic. I do have my medical assistant is an athletic trainer, and so she can go over the exercises with them as well. So.
Yeah, good.
We have that same issue. I think Ashley can elaborate more, but she spends most of the time on the phone doing that because, like Dr. Safran, most of our patients don't live local. They're coming in from all over the country or world, for that matter, like Dr. Safran's do. So we have quite a network that we use. And I know that's a jumping topic here, but with ISHA, that's something that Ashley and the team is working on to develop a better network. I know Marc's been wanting this as well, that we're trying to create this national network of providers that we can work with. Because a lot of our patients, it's a lot of phone work and following up and using telehealth.
That'd be great. That'd be a huge advance.
Mhm.
Yeah. So Ashley, can you tell us what because like I'm sure you see a lot of patients who have seen other therapists aren't doing well, and then they get in to see you. What are some of the key things that you think you see commonly that maybe should have been done or was maybe missed that would help specifically for the instability?
Yeah, so a couple of key things. Like I said before, a lot of them have these extra-articular, peri-articular issues going on, TFL, glutes, iliopsoas. I mean, everything can be super irritable. And if you don't calm that down in some form or fashion, everything kind of stays irritable. And it's really hard for them to get over kind of that pain inhibition. So we always prescribe, soft tissue work and modalities and whatever they need to do, and we might put them on anti-inflammatories to help with that too. But there's a lot that can be done in therapy to just calm down the soft tissues prior to starting the exercises. Now, that doesn't mean that our expectation, and this is where lines get blurry because patients like to say one thing different than what we've actually said to them. I try and make it very clear that my expectation isn't that it's not that they're going to get a massage for an hour, but they do need some hands-on stuff, and their exercises shouldn't be painful. That's a big thing, is this idea of like no pain, no gain, just push through it. Or if the patient's not telling them that the exercises were hurting while they were doing them. So hands-on being left out and your various modalities that can help with pain control being left out is a problem. And then the other big thing is kind of an over-reliance and overuse of more of your classic glute strengthening exercises, like your clams and, big muscle exercises, versus really trying to get those local stabilizers going, because they're already kind of overworking all the prime movers. Again, the iliopsoas does need strengthened, but you have to be very cautious on how you do that. It can be a slow process, and you don't want to just start hammering away at iliopsoas strengthening, because it's just going to make it worse. So a lot of it is just, it's not necessarily, I always say it's not necessarily the therapist is bad or they don't know what they're doing. It's just, these are kind of complicated. And if you haven't seen a lot of them, you don't really know what order or sequence to go in. But a lack of hands-on and then focusing more on prime mover strengthening too early are probably the two biggest things I see.
Awesome. Dr. Safran, did you go to Duke?
I did my med school at Duke, yes.
Yeah. We should give another shout out to Terry Malone. He told me to give you a hard time for Duke.
Well, that seems to fit, because those athletes are soft too.
Wow.
Ouch.
Boy's going hard on everybody tonight.
I'm getting lots of emails.
Yeah, you are.
But we're very cerebral, both groups. Very cerebral.
100%. I don't want to get a GRE exam.
See, physically soft perhaps, but academically very, very good.
And I have nothing to say. I help out at Vanderbilt. So what am I talking about?
Did you, Ashley, did you want to go to our other special guest, or do you want to continue
Sure.
a little bit?
Yeah, I know we're kind of down to the last 2 minutes. Just some
Dr.
people,
Safran, thanks for coming, by the
a
way.
couple
before
of
we,
people
log
said
out.
that they didn't see that PDF I put in there. I'll go, whenever we're done, I'll go throw it in the Google Drive where you guys got the articles as well, just so you can have access to that. Let me see if I can pull our friend, Dr. Plancher in here as a panelist for just a quick. Oh, can you, oh, there we go.
There's your OSAT mug. There you
Here he
go.
comes, here he comes.
I got my instant mug right there for Plancher, right
Nice.
Oh,
there.
that's right.
All
There we
right,
are.
Dr. Plancher, are you here?
I'm trying.
There he is. Oh,
There he
There
is.
it is.
There he
he's
is.
got his
So-
Hey,
crocs.
Dr. Blanchard. There's the cow.
Notice that
I
crotch.
need you to push it, to close it. 1 second. I'm
There it
sorry
is.
because I didn't know if we do it, but I got it. Hi, everyone. I know I only have a few seconds. And so I want to say it's Ortho Summit time, September 13th through 18th, and I have a special deal to offer IJSPT. Well, it said $4.99. It's $3.50. We're sending a code because we love you as therapists. And so I encourage you to come. Mike and Ashley will send you the code. That's why I wanted to special say hello, Mark. And I hope that I just need a receipt.
We'll give you one for that.
Okay. I need a receipt.
For $3.50, I'll give you 5 receipts.
All right. Well, can you close the door? Can you close the door? Close the door. And so I really look forward to seeing as many of you. I'll let Ashley give it's a little Chicago, there's always violence in Chicago. My
Hey,
dog.
get that right.
I think you'll know, Ashley, I think you have to do the selling. So I would do that. You know what I mean?
Well, we just know it's a great collaboration meeting, lots of opportunity for the therapists. We promoted it at the start of the meeting, so glad you could jump on. And that's awesome to get a code for $3.50. That's an amazing deal for so much education and just
It's
lots of
about
opportunity.
30 CEUs and CMEs.
Yeah.
And we're at the Fontainebleau Hotel in Las Vegas this year. And I look forward to seeing all of you. There's some surprises you may find. There are keynote speakers. There are athletes like Joe Theismann, and we have someone probably coming from Shark Tank. So
All right. Well, it sounds like a party.
There.
The party.
So
And I'll
there's
say
a
the same.
lot to be
I'm going to
had.
echo. I'll jump in here real quick. I'm going to echo what Ashley said, and I know Dr. Safran knows this. But for all the people who are on the call tonight, in my opinion, it's one of the best meetings you can attend for networking. And in fact, the whole panel tonight that we have with Journal Club is going to be there speaking. So I would encourage everybody to look at that. Like I said, it's one of the best meetings in my book that you can go to.
Well, I thank you for that, but science is serious, and we can't do it without collaborating with you and surgeons together. So I look forward to and thank you for letting me have some airtime.
Thanks, Dr. Plancher. Have a good night.
Thank
Bye-bye now.
you.
Good to see you, Kevin.
Yeah.
Bye-bye. Bye, Mark.
Hey, see ya.
Well, thank you, Dr. Safran. I know we're over time here. I do want you to answer this one question because I know Dr. Bird's answer to this, so I want to hear yours. But Dr. Safran, what's your indication for an iliopsoas lengthening procedure given the importance of iliopsoas strength?
So I basically do it for patients who have pain after total hip replacement, and but otherwise, it's pretty. It's a rare iliopsoas to lengthen. Yeah, especially, I absolutely can't say it strongly enough. If somebody's femoral version is greater than 25, don't even touch it, because the reality is it hurts because it's being overused because they're unstable. And if you do it, you're going to make them more unstable and make them miserable and weak. So it is a rare person that I'll do an iliopsoas lengthening, but they have to have pretty much normal femoral version, failed the injections, had short-term relief of the injections, failed the injections, failed the rehab. But it is like, I used to do iliopsoas lengthenings maybe once or twice a year. I probably do it maybe every 4 or 5 years. It's other than total hip patients.
Yep. And 10 years with Dr. Bird, I've seen him do it on a non-total hip patient twice.
Wow.
It's about right.
So very rare. Well, thanks everyone that stayed on. Certificates will go out in the next 24 hours. Huge thanks to Dr. Safran.
We need to bring him back. There's all kinds of
fan
stuff.
favorite.
We didn't
yeah.
even
We're
gonna
like
hit
get
him
the
up in
tip
the
of the
fall to come back.
iceberg. I know.
All right.
It was
Everyone,
awesome.
have a great
It's
night,
an honor
everyone.
for me.
Thanks,
Bye,
Thank you so much for
everybody.
the invite.
Thanks, Dr.
I really
Safran.
appreciate it.
Thanks, Dr. Safran. We
Thank
appreciate
you all.
you.
Y'all. Thank
Yep.
you so much.